The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matt Watto here with some great friends. But first, I'll introduce America's primary care physician, Dr. Paul Nelson Williams. Paul, how are you doing tonight?
I'm great, Matt. Excited to be doing a Hotcakes. I feel like it's been like half a year since we've done one, so it's nice to actually
I think that's
go back to literature
pretty true,
and catch up.
Yeah. At least a quarter of a year. And with us tonight, the great Dr. Rahul Ganatra. He is our, our resident epidemiologist, Paul, is he a whiz kid? How do you describe Rahul?
Oh, stop.
Well, it's not, because we already have a hospitalist whiz kid. Wunderkind? Is that?
Oh, yeah, there we go. Yeah, I think that's good.
Excellent.
Yeah.
Although I don't want to be associated with Nate from Ted Lasso.
Don't know the reference. Never will.
Paul refuses to ever watch Ted Lasso. Paul, before we get into it, can you remind people what is it that we do on the Curbsiders, and what will we be doing this evening?
Sure. Happy to, as always, Matt. As a reminder, we are usually we're always the internal medicine podcast, and we typically use expert interviews to bring you clinical pearls and practice-changing knowledge. The Hotcakes, the beloved Hotcakes episodes, are a little bit different in that we each have reviewed an article that is exciting or interesting or potentially even practice-changing, TBD, and sort of went through it and tried to apply some critical analysis to it and decide if it's how we feel about it and try to learn a little bit about how studies are done in the process.
Yeah. That's right. And a reminder to the audience, this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. And we'll kind of stick to a format. So first up, we're going to have these Hotcakes where we go a little bit more in depth. And then at the end, we have a couple more newsy items. So we're going to be talking about ketamine. We're going to be talking about a new non-hormonal therapy for menopause. Paul's going to be talking about metformin and whether or not it works to treat prevent long COVID.
Yep, just in the nick of time.
Yeah, just in the nick of time. We'll talk about the new breast cancer screening recommendations, and finally, Kratom, which if you haven't heard of it, Paul's going to tell us about it. It's a new party drug, ? Not really. No, over the counter.
By new, you mean centuries old, and just Americans are misusing it per ? We'll talk about it.
Right. Okay. New to me, Paul, because I am not cool. All right. Rahul, so can you tell us the article you chose? What's the article, the authors, and, let's get started.
So the paper that I'm going to be talking about is the ELECT-D study. And this was a paper by Anand and colleagues, and this was published in a June 2023 issue of the New England Journal of Medicine. So what was this paper all about? This was a study looking at the use of ketamine for severe treatment-resistant depression. So what was the research question here? The question that the authors were asking was, is ketamine non-inferior to electroconvulsive therapy, or ECT, in the treatment of moderate to severe resistant depression? So why is this study important, particularly for generalists like us to know about? Well, about 1 in 3 patients with major depression have a suboptimal treatment response, and that's even after 2 good trials of effective antidepressants. And ECT is something that generally works well for patients in this situation, but there are downsides. For example, it's not available everywhere. It requires general anesthesia. There is still some stigma and fear around the use of ECT. And there are adverse effects, mainly affecting patients' cognition and memory, that are thought to persist for up to a few months. Ketamine is increasingly being used at sub-anesthetic doses for treatment-resistant depression, but prior studies have not really been a slam dunk that this has high efficacy. So this study aimed to clarify that. So how is this study done? Well, this was a randomized, unblinded, pragmatic non-inferiority trial. And this was done at 5 hospitals in the United States from 2017 to 2022. And this was funded by the nonprofit Patient-Centered Outcomes Research Institute, or PCORI. Patients were randomized 1-to-1 to get either ECT, done 3 times a week for 3 weeks, or to receive IV ketamine, which was administered 2 times a week for the same duration, 3 weeks. And patients could continue their existing medications, with their sort of usual providers. These were not standardized. And the primary outcome in this study was clinical response, which was measured as a 50% or greater reduction from baseline severity on a questionnaire, the QIDS SR16. And this was basically an inventory that's a quantification of the SIGI CAPS symptoms that you learn about in med school. So the primary outcome was assessed at 3 weeks, and then patients who had a response to either treatment were followed for a total of 6 months for assessment of secondary outcomes and durability. So who were the patients in this study? Well, patients in this study had to have at least moderate depression, and they had to have failed at least 2 antidepressants previously. And patients couldn't have had psychotic features because there's some worry that ketamine might worsen symptom control in patients with psychosis. So they included patients who were in their mid-40s, roughly equal proportions men and women. Essentially, everybody was non-Hispanic white, and 90% were outpatients. And these people all had pretty severe depression. The average duration was over 20 years, with a median of 5 previous episodes. The majority of patients had a family history of depression, and 1 in 3 patients in this study had a history of attempting suicide. A lot of patients had concomitant anxiety, but comorbid substance use disorders were uncommon. So what did the study show? What were the top-line results before we get into discussing some cool things about it? So the top-line findings were that at 3 weeks, 55% of patients who got ketamine had a clinical response, compared with only 41% of patients getting ECT. And the non-inferiority margin in this study was 10%. And the absolute difference in this study was it was positive, well above the negative non-inferiority margin. So 14% difference between groups. And the confidence interval was nowhere near that non-inferiority margin. So the authors determined that ketamine was non-inferior to ECT. And a lot of the secondary endpoints really supported this. And I will note, though, that both groups saw an improvement in quality of life at the end of this 6-month follow-up period. So before I open it to discussion, the last thing I'll just add is that in terms of adverse events, there were differences. Musculoskeletal problems were more common among people who got ECT, and as you might expect, dissociative symptoms were more common with ketamine.
Yeah. And the ECT is basically inducing a seizure, I guess, as part of how it works, which is probably why people think it's scary. Rahul, I noticed, because this was an open label trial, that there was, when they talked about how some patients, after they found out which group they were randomized to, there was about 30 patients dropped out of the ECT group, maybe because of that scariness that we were just talking about, and only 8 patients dropped out of the ketamine group. So I was just wondering if patients, if this was kind of marketed as a ketamine study and that was the big draw, because at least I hear a lot about ketamine. Maybe it's just like the podcasts I listen to, people are talking about ketamine.
Or the podcast that you actually run, because it was actually just brought up with our substance use disorder episode that just came out, I think, this week.
Yeah, true. So in my world, in general, thank you, Paul. So in my world, ketamine it just seems to be a hot topic.
Just everyone's getting ketamine. It's just willy-nilly
psychedelics.
out there.
Yeah, as do psychedelics. And so I just wonder, Rahul, do you think that is a potential source of bias for this positive trial?
Yeah. So great question. And I will say, I mean, it's not just you. Ketamine, I do think, is really entering the zeitgeist for the treatment of resistant depression. And, as a generalist, I've had to do several sort of pre-procedure evaluations for patients who are going to receive ketamine for severe depression. So this is something that I think, we'll start seeing more and more of. But yeah, as to your question, so this in the vernacular is a positive study because the primary endpoint of non-inferiority was shown. And one thing I'll just say that I put out there for listeners who I'm just inviting you to please tell me what I'm missing about this. But I think that the results are compatible with superiority of ketamine over ECT because the confidence interval doesn't include 0 for the absolute difference there. The authors are very cautious about this, and they don't actually say superiority in the paper. Mm-hmm. And I have tweeted about this, and nobody is responding to me. So
I've been watching.
Yeah. If I was hoping somebody was going to have the answer, I'm wondering what I'm missing here. So listeners, please, help us solve this mystery.
And with the non-inferior margin of 10%, so it could be no more than 10% worse, right? But it was actually 14% better, but in absolute terms.
That is correct. That is a perfect statement in words of what that means. I love it. So and so listeners, help us learn, participate in this with us. What am I missing? So at a minimum, the authors found that ketamine was non-inferior to ECT. And Matt, the point you raise about the people who were who kind of didn't complete the assigned treatment, this is an important thing. This is called differential loss to follow-up. 16% of patients randomized to ECT didn't do it. Only 3% of people assigned to ketamine didn't do it. So this is a source of selection bias that occurs after randomization. And, in this study, since we know that ECT is an effective therapy, I would expect this to bias towards ketamine looking better because more people in the ECT group did not get an effective therapy. So that's an important source of bias towards, ketamine looking better there.
Paul, and we talked a little bit about this. I mean, I don't know that I've seen a case of ketamine dependence, but I believe it's a condition that exists. And the editorial that accompanied this in New England Journal, the editorialist was just like, remember, we had this opioid epidemic because we were just kind of prescribing people opioids. Do you have that kind of concern, Paul, as you're largely an addiction medicine physician these days, even though you like to be humble about it?
It's, I've not seen enough of it to be concerned yet. It seems like it's on the uptick. And I think that your point is well taken, that there just seems in general to be out there in the Gestalt a sense of wild enthusiasm for ketamine as a use for almost anything. Like I remember for certain withdrawal syndromes, I've seen it sort of thought for depression, for management of alcohol use disorder. Like it seems like we're just trying to look for reasons to use ketamine now. So I think the wild enthusiasm is the thing that makes me probably a little bit more cautious. So I've not seen it as a reason to be concerned in the patient populations that I've taken care of yet, but that doesn't mean it can't happen.
And I just want to say there's one other source of bias that I could identify for ketamine looking better in this study. And that was something that the editorialist pointed out in the editorial. This is out of my area of subject matter expertise. So this is an example of an area where having subject matter expertise can really enhance your critical appraisal. But the editorialist talks about how in this study, all of the ECT treatments started out as unilateral. And, from what I understand as a layman, the intent of that is to try to reduce the incidence of side effects, but that's also less effective than bilateral ECT. And 40% of patients in this study had to be switched to bilateral ECT. So, if they started with a less effective version of ECT than what, would be done for patients like this in the real world, that's another potential source of bias for ketamine looking better.
Rahul, so I think we should get a Hotcakes rating for this, and what's your final take home? Is this, do you think this is practice changing? Not that you're prescribing either of these therapies, so
yeah. From the outside looking in, I think this is a pretty well-designed study. There are a couple sources of bias towards ketamine looking better, but what this study did persuade me of is that at least in the short term, there don't seem to be obvious drawbacks to the use of ketamine. And looking at the primary outcome in different ways with different surveys and using sort of different cutoffs, the results showed some consistency. So this is kind of encouraging, particularly for people who can't get ECT due to access or other contraindications. I think ketamine could emerge as an important tool in the arsenal for these patients. So I'm going to give this 4 out of 5 hotcakes. I'm excited.
Yeah. And I just think, we've raised our concerns about dependence. So I think enough said about that. I mean, that should be with any substance you're introducing, this kind of substance anyway. All right. So we'll move on.
I will say,
Paul?
just real quick, I don't think I've ever had a patient that is identified as having been treated with ECT. So I just, in terms of having another possible option that is available to someone who has treatment resistance is also, exciting in of itself. So you're right. Like, we may not be doing it ourselves, but it's just to have something in our arsenal is just at least nice to know about.
Yeah. So I covered, Paul, Skylight 1. This is a study of a new non-hormonal therapy for the vasomotor symptoms of menopause, which we talked about, Paul. I can't remember if it was SGIM or ACP, one of our conferences that we attended this year. Yeah, maybe even both. So this was a study by Lederman et al., and this was the use of fezolinetant for the treatment of moderate to severe vasomotor symptoms of menopause. It came out in the Lancet in 2023. And Paul, what do you think of the Skylight 1 as a title for this study? How do you, as a big trial head?
Yeah, no, I appreciate you asking, because I think, I didn't have a whole lot editorial to add in terms of sort of your review of this, but I don't think I understand the pun in terms of relation to vasomotor symptoms of menopause, if there even is one. Is like, how does Skylight relate to that? Because I feel like I'm missing something important here. And if it doesn't, then boo. Like
you know what, Paul? I couldn't figure that out. Audience, tweet at us if you know why it was titled that. It's not. They didn't cram in an acronym that I could find. So I'm not sure, Paul. But they had Skylight 1 and 2. They had a Skylight 4. They've been using this name all over the place.
They really leaned into it. So like it has to be something. I feel like I'm just missing something. So apologies to the trialists.
So the question here was, does fezolinetant, which is a neurokinin 3 receptor antagonist, does it reduce the frequency and severity of vasomotor symptoms and improve quality of life? They were also looking at safety. This is important because not everyone can receive hormonal therapies just because of contraindications. Some people don't want to take hormones. The 2023 NAMS, the North American Menopause Society, has 2023 it's a position statement on non-hormonal therapy. They actually included this as one of the highest levels of evidence in there. I'm used to using SSRIs, SNRIs, gabapentin, some of these for hot flashes, but this is now included in the higher level of evidence within that guideline by NAMS. And so I was surprised to see that the guidelines came out in like June, and this study is from April, so they got it in there pretty quickly.
Yeah.
So why is let me tell you the top line results. So this was another positive study, and they looked at 2 different doses, the 30 milligram and the 45 milligram dose of fezolinetant, and they found that it is efficacious for reducing one of the co-primary endpoint, which was frequency and severity of symptoms. And the women had to have at least 7 hot flashes a day. Actually, at baseline, all the groups had something like 10 or 11 hot flashes, and both of the fezolinetant groups, by the end of 12 weeks, had decreased to 5 hot flashes or less on average per day. And in the placebo group, they decreased to 7 hot flashes or so per day. So both groups decreased, but 2 points, two less hot flashes per day with the treatment. The severity was a little harder to interpret because they were looking at a scale of like 1 to 3, mild, moderate, or severe. And they said that it decreased by like 0.25 points on a scale of 3. So I don't really know what to make of that, but it was statistically significant. They tried to look at sleep, and they actually didn't. It did not improve sleep disturbance based on the scale they were looking at. It seemed like there was some improvement in quality of life. I tried to look at this menopause quality of life questionnaire they use, Paul, and I couldn't. It was a little bit hard for me to interpret the least mean square change in that.
This was actually a question I had for Rahul in terms of this least mean squared comparison. Like when would you use that? Why would you use that? I tried to sort of parse out the graphs and the figures in the study, and I was like, well, those lines look bigger than those lines. But other than that, I couldn't quite figure it out. So would you mind sort of talking me through that concept specifically?
Yeah, boy, this is an area that, with regard to how it's done in this study, I'm not sure I understand well enough to be able to explain. But I do think that the use of this measure, really what Matt was describing with, the ordinal scale of like, mild, moderate, severe, and then, showing a sort of quantitative difference between those two. The way that they've reported this is not easy to interpret. And, that's in and of itself kind of an important learning point in my view, because, if results are not easily interpretable, then it's kind of hard to know what to do with them.
Yeah.
So, I mean, to me, that the 0.25 suggests that that's like a, less than 1 category improvement as the average treatment effect for this medication. What might be more informative is, what percentage of women, went from severe to moderate or moderate to mild. And that data might be available in the supplemental data.
Yeah.
So when I encounter a outcome measure that I don't really understand, I just think to myself, what would be the sort of, way that I would want to use this, or how would I operationalize this? And then I look for that expression of the results in the supplement.
Yeah,
that's great.
So I like that. I didn't think to do that, to look for how many women went from severe to mild, or at least decrease their category fully. I just think that in general, let me make a complaint to both of you about research. It is I know we have this patient-centered outcomes that are becoming more and more, but it's like, they put it in terms that like you have to be a statistician to understand. Like, why not say like, we use this scale, a meaningful change on this scale is this many points. We saw this many points. Like, I feel like sometimes they don't want to give that information because they just want to have the positive headline of, we had a p-value that was significant, but really that doesn't translate always, or often doesn't translate to something that I care about or the patient cares about.
Yeah, and I'll just put myself out there. I theoretically am the person in the room who's like supposed to be the most interested and know about this stuff. But I mean, I encounter stuff all the time that I don't know how to interpret. So I do a lot of Googling. I do a lot of scouring Twitter to see what the discussion has been on some of this stuff. So yeah, after we're done recording, I'll spend some time looking into this and I'll report back.
Maybe not tonight. Go to sleep. Maybe another day.
I feel like this is
Typical
a perfect snapshot of our different personalities, by the way. So Matt is like, I think it might be obfuscation. Rahul's like, this is a chance to learn. I'm like, I must be a dummy. Like, it's just, I think this is like, this sums us up perfectly.
All right. Well, let me just
back to the
wrap up one or two more points about this study. So there were 3 groups. 2 groups, they got a 30 milligram dose, a 45 milligram dose of the study drug fezolinetant or a exact match placebo. And then this was, they had to screen 2,200 patients, Rahul, just to get about 175 patients in each group. And so we both calculated this is about 25%, only 25% of the patients screened made it into the study. Does that seem like a source of bias for you as far as the results go, this being a positive trial?
Yeah. I mean, there's not that many tools we have available to kind of decide how highly selected is a study population. One of the only tools that I think is routinely reported is in the consort diagram, the percentage of or the number of patients who are screened and the number of patients who are ultimately enrolled. So I feel the best about studies that enroll a high proportion of patients who are screened. To me, that suggests that the population is not highly selected or cherry-picked.
Yeah.
You feel great about a study that's 95%. You may worry a little bit about a study that's, 5 to 10% and ask why. That's not by, just de facto a source of concern. It's just a signal that that's a question we should ask. And in this study, the biggest category of patients who were excluded was listed as other. So no specific reason given there. So that does raise my concern a little bit for selection bias in terms of the study population.
But the exclusion criteria, you couldn't have a cancer, either current or previous, unless it was like a basal cell skin cancer, any chronic kidney or liver disease, even blood pressure above 130 systolic was like a no-go. Or if you were treated, then it sounded like there was a little wiggle room there for the authors or, for this trialist to include you. But this was really a healthy group of women between the ages of 40 and 65. And they were from mostly like US and European country, like US, Canada, and some European countries. So, I do think there were some sources of bias. Safety outcome wise, they were keyed in on some liver stuff because there were some other agents in this family of there's these things called the candy neurons, KNDY. It's an acronym.
No, I know that.
And this neurokinin. Let me make sure I'm saying the right name now. Yes, neurokinin 3 receptor antagonist is one of a couple different agents that they're trying to use to target these neurons, which are involved in thermoregulation and hot flashes, essentially. And one of these drugs previously had some signal for liver damage. That's why they're really keyed in on the liver. And practically speaking, for listeners, this has been approved, FDA approved, at a dose of 45 milligrams once a day for vasomotor symptoms of menopause, based on this trial and some of the other ones. And they want you to check liver enzymes at baseline 3 months, 6 months, 9 months for the first year. So basically every 3 months for the first year that they're on the drug. In this study, about 1 patient in the placebo group, 2 patients in the 30 milligram fezolinetant group, and 0 patients in the 45 milligram group had liver enzymes above 3 times upper limit of normal, but no one had like catastrophic,
there's no
liver issues.
Liver failure. Yeah.
Yes. So, it seems like it was okay. Rahul, before I give my hotcakes rating and, whether or not this will be practice changing for me, did you want to give any other points about this one?
Yeah, the only other thing that stuck out to me about this was a phenomenon that we've talked about on prior Hotcakes episodes, and that's the idea of regression to the mean.
Mm-hmm.
And this is something that you have to look out for anytime enrollment in a study is contingent on a patient having some extreme value of something.
Yeah, the
So in
7
this-
hot flashes.
Exactly. Yeah. So, not being a person who's ever experienced menopause, I don't know if that's a lot. It sounds like a lot. And, the patients in all the groups ended up having a mean of 10 or so, 10 to 11 per day.
Yeah.
And as you mentioned, we saw that even the placebo group declined down to like 6 to 7 or something. And figure 2 shows that nicely. That is something that could be explained by a beneficial placebo effect. Or that could be this phenomenon of regression to the mean, just by when you select a group of people based on an extreme value, over time, they tend to regress to the mean. So if you didn't have a placebo group in this study, you wouldn't know if that's why patients who got the study drug improved or not. So this is another illustration of why, placebo groups are really critical.
Yeah. So, I will give this Hotcakes rating maybe a 3.5. I'm always a little skeptical of these fancy new medications, industry funded. Four of the authors of this trial were employed by the Astellas Pharma, who makes the medication. I'm still going to wait a little bit. I think maybe if this starts getting rolled out to more and more patients, like, will some of these liver issues become more prominent? I think in practice, it's hard to get a group of patients this healthy. So I'm going to give it 3.5 because a lot of my patients in the 40 to 65 would have been excluded from this. So I'm not going to be rushing to start prescribing it for patients. But I do think overall, otherwise well done trials. 3.5 Hotcakes out of 5.
It seems fair. Like, I'm with you. It's so new, and we have non-hormonal medications, even though they're not necessarily FDA approved. Like, I was trying to look this up before we started doing this. Like, the venlafaxine seems to reduce symptoms by about like 40%. So not too far away from what's being reported here, especially since I don't fully understand the results here. So I will probably lean on the ones where I know that venlafaxine is certainly an imperfect drug and has its own issues, but at least I know what those issues are,
right?
Because it's been around for a while. So I might just stall a little bit and kind of see what else shakes out before I have too much wild enthusiasm for this class.
There's a special Paxil salt that's like 7.5 milligrams daily that is FDA approved.
Yep.
And has evidence. So anyway, there's I think we need to hear more on this, but I do think the audience needs to be aware of it because patients are going to be asking about it. I'm sure they're going to be advertising. It's included in some guidelines with a high recommendation. So I think we're going to start seeing this out there. Paul, you want to get to your article?
Sure. Yeah, no, timely. I'm going to tell you all about an article by Bramante et al., and apologies if I mispronounced the name, from Lancet Infectious Diseases from just, I think, like this month. Like, this is actually, I don't think even in print yet. This is still e-published right now. And this is the outpatient treatment of COVID-19 and incidence of post-COVID-19 condition over 10 months. This is the COVID OUT trial, a multi-center randomized quadruple blind parallel group phase 3 trial. So rolls right off the tongue. But basically, it's what they were looking at. So it's an interesting paper because this is a secondary outcome from another study looking at reducing the incidence of severe COVID with several medications I'll talk about. So presumably our listeners have heard of COVID-19 at this point now, and also long COVID and prevention of long COVID. It's starting to feel blessedly kind of less relevant right now. Like, I'm not treating and seeing as much COVID, though it's still out there, and I still think worth thinking about. So in any case, I think the paper does have some relevance and also maybe even mechanistically understanding what's going on here. So the research question, just to actually get to the meat of what the paper is does outpatient treatment with metformin, ivermectin, or fluvoxamine soon after COVID infection reduce the risk of long COVID? So the investigators were looking at, do any of these study medications reduce the incidence of long COVID? And the long COVID question is important because of all the patients that have had COVID, which feels like everybody at this point now, there's like almost 20%, according to the CDC, reporting symptoms of long COVID, which unfortunately, to my mind, long COVID is not super well defined other than having symptoms that persist longer than 3 months that can't be explained by something else, which still seems a little bit unsatisfying to me, but I just don't think we have anything better right now. And it's also worth noting that long COVID disproportionately affects patients who are from racial and ethnic minority populations. So it's important to kind of figure out what's going on here and what things that we can do to address it. So I'll talk about the study design in a second, but the top line result, the thing that we should be thinking about as we're going through the study design, is that outpatient treatment of acute COVID with metformin, specifically of the medications that we're talking about, reduced long COVID incidence by 41%. And this is important because that's a big number. We have something that has a fairly high incidence and prevalence, and metformin safe and low cost and easy for people to get. So how do they actually figure this stuff out? Any questions so far before I roll on? Because that was a lot of words out of my mouth.
One comment was because I looked this up because 70% of the patients in this study had Delta variant, and right, and maybe a third or something had the Omicron variant. And I was, because now Omicron is, Omicron has been the most recent variant as of this recording. And look, there was a paper that just came out recently talking about how about 10% of patients are progressing to get long COVID after the Omicron variant. So that was my comment. The second thing I wanted to ask, Paul, the 41%, that was a relative reduction in COVID, right?
Correct.
It was the absolute reduction was like 4% or something.
Yep, exactly.
Yeah. Rahul, can we call that a number needed to treat of 25 with like based on this? Is this the right type of study where you can calculate a number needed to treat, like absolute risk reduction of 4%, roughly 25?
Yes. The short answer is yes. Anytime you have an absolute risk reduction, you can equivalently think of it as a number needed to treat over the time frame of the study. Mm-hmm. There is a slightly longer answer when you're using person time data like this that is, not important for us to go into on the air. But I did find this explained beautifully in a short letter that we can link in the additional reading section for this one.
Okay, great. Thank you. All right, Paul. So sorry to interrupt.
No. I think this is good. But how the study was kind of designed, I'm fascinated by, just because it's complicated yet understandable, which is my perfect combination as far as I'm concerned. So this was, as I mentioned, investigator-initiated, randomized, quadruple blind, which means I think that you had to have your eyes closed when you wrote the paper. I think that's the last part of the blinding. It was placebo-controlled, and the primary outcome that they looked at was severe COVID-19 by day 14. And then the secondary outcome, as I mentioned in the focus of this paper, is the incidence of long COVID. And so basically what they did is they followed the patients over the course of 300 days with monthly follow-up, identifying who got long COVID by asking them, did your doctor tell you that you had long COVID? And then they went to the chart and sort of confirmed that. And the patients were recruited remotely. There was no actual direct patient contact. It was via patient portal, online advertising, and then there were advertisements at the 6 clinical sites. And you could make an argument that might select for people who have a little bit more access to technology or sort of a higher technological literacy. But not so much that I had a huge problem with that. And it's a factorial design so that the patients were randomized. All right, brace yourselves. Are you ready? They received either metformin plus ivermectin, placebo plus ivermectin, metformin plus fluvoxamine, placebo plus fluvoxamine, metformin plus placebo, or placebo plus placebo. So everybody got 2 pills, and it's this factorial design that allowed them to kind of compare and contrast the actual true effect of the medications that they were looking for, if I understand things correctly. And the medications were given for 14 days. They received delivered. They were prepackaged. And the statistic that they cited, which I found fascinating, is the time between consent and the ingestion of the first dose of study medication was on average less than a day. So by the time that the patients were qualified for it and consented for it, they had the medication the same day and it was in their stomach. So fascinating how efficient things were. Mm-hmm. And then after 60 days, surveys were sent every 30 days, up to day 300 via email, text, phone call, letter, depending on what the patient actually preferred. So far it makes sense.
Yeah. I mean, this was done, this was still, I think a lot of the country was still locked down when this was happening too. So that's even more impressive that they were doing this.
Yeah. And the analysis, I know, Rahul, maybe you can jump in here and correct me if I'm wrong, but the decision to study this, I think, occurred after they had already designed the study to look at the primary outcome. And then I don't even think long COVID had been sort of defined as a thing. And then they sort of decided to kind of attack this on as a thing to sort of study an additional, which is not a criticism necessarily, but I just think an interesting that this was pretty early on in things when they were actually putting this together.
That's right.
So the patients that were included in this, they were aged 30 to 85. They had to be either overweight or obese and had COVID symptoms fewer than 7 days with a documented positive antibody PCR or antigen test within 3 days of enrollment. Patients were excluded if they had prior COVID, if they were previously exposed to the study drugs, which I think is really important here, which means, for most patients who have, say, type 2 diabetes who are on metformin, were not included in the study population. And then patients who were treated with any of the EUA, FDA medications were also excluded. And vaccination status did not impact enrollment. And then also, importantly, pregnant and lactating patients could be enrolled, but were only randomized to metformin just for safety's sake. So that is the study. So at the end of the day, we talked about the sort of decrease that showed for the patients solely with metformin. The other study medications did not show a decreased incidence of long COVID. And in fact, that was consistent with the primary outcome as well. So the metformin reduced the development of severe COVID-19. The other medications did not. And then similarly with the secondary outcome that's being looked at here, only metformin showed a reduction in the development of long COVID. The fluvoxamine, the ivermectin did not show those things. So this was the one medication that seemed to actually have real promise.
This was surprising to me because I just remember, I remember the initial results of this study coming out because that was sort of, that was part of the ivermectin fight that I think is somewhat, maybe it's still going on.
Thank
I
God
don't know,
that's
Paul.
over.
I try to keep my head out of it, but the ivermectin, that was part of that fluvoxamine, because I had patients calling me asking, should I take fluvoxamine? Should I take ivermectin? We were trying to find off the shelf medications that already were around, cheap, and we know are safe to give to patients that would work. And as you said, they tacked this on. But what is the mechanism with this metformin? I mean, did they say?
They have a theory. Now, the theory is that there are some, I feel like this is the usual theory for most things. There's some anti-inflammatory properties that for listeners at home, there was some hand waving going on there. And then there is potentially antiviral effect, though I looked at the papers that was referenced, and that seems to be primarily an in vitro and ex vivo effect, and that has not been demonstrated sort of in other circumstances. So it really is purely theoretical at this point.
Yeah. Mm-hmm. Well, so Paul, I mean, is this going to change practice for you? Where we are right now, fortunately, I think people are demasked, largely demasked, and we're not having our hospitals fill up with patients with severe COVID. So I'm not sure if you'll be prescribing this for your patients if they call you and say, I have COVID.
No, I think that's right. This is not practice changing for me. I do think it's compelling because I think it hopefully offers some mechanistic information for people smarter than me as to who might develop long COVID and sort of how it works and sort of some of the immunology behind that. Like I think the relationship between COVID-19 and the development of new diabetes, for instance, is really interesting and sort of, patients with diabetes had worse outcomes, and yet these patients without diabetes who were put on metformin seem to do better. So what do we do with that information? So I'll leave it to the pharmacologist and the immunologist and the virologist and on and on to kind of figure out exactly what that means. But it seems like there has to be some sort of mechanism there that hopefully can be taken advantage of, maybe help patients or prevent, God forbid, in future, pandemics,
future pandemics,
post-viral complications. So I think it's promising and compelling, but is not practice changing. I agree. So if I were to give a Hotcakes rating, I think probably 3 for being interesting, but I have to dock it for not being immediately practice changing.
Yeah, when I read this paper, I couldn't help but think if I had read this in 2021, that would be a totally different feeling for me. And it just is a reflection of the fact of, and this is a problem that affects all of the literature on COVID therapeutics, which is that the study populations that those were carried out in just don't exist anymore. Pine Tree, the studies of nirmatrelvir, ritonavir, those all the studies were carried out in a largely unvaccinated population. And nowadays, it's thought that upwards of 95% of people have some degree of immunity through a combination of vaccination and prior infection. And in this study, in their subgroup analyses in Figure 3, they did break out the results by vaccination status. And the effect was attenuated completely in patients who were vaccinated. So, the utility of this knowledge in 2023, I agree. We're really in a different place than we were when we first learned about long COVID. And all the millions of people who are affected by persistent symptoms. I mean, this is still an unmet need and deserves real attention and careful thought and problem solving. But I'm just worried that this study population is going to be really hard to identify in the current day and age.
Yeah.
Find someone who has not been exposed or who's not had a COVID infection now it's almost not easy to do at this point.
Or been vaccinated 16 times.
Yeah, yes, exactly.
So let's move on. We have two quick hot takes. So the USPSTF, Paul, who we've been doing some shows with recently, have put out a draft recommendation on breast cancer screening, which is certain to make a lot of headlines once it's finalized. And I think we're certainly going to look at, right now, we're screening people at age 50 every other year. So every 2 years, starting at age 50 for women who are at average risk. And now they're going to start to recommend screening every other year for women at age 40 up through age 74. And so this is a big change, dropping the age by 10 years. They say that this is driven by, we're seeing breast cancers in younger women. And also there's some disparities, particularly Black women tend to have worse outcomes with breast cancer. And so they're hoping that by starting the screening age earlier, more people will get screened, will catch more cancers, more people will benefit from this. The other two things they comment on are what to do with women over age 75, and they continue to give that an I grade, which is, we don't know, inconclusive. Yeah. And the same thing for what to do with women who have dense breasts, which again, they gave an inconclusive rating there. So do we get supplemental MRIs or ultrasound, which is a question I get all the time and I just don't have a good answer for. So basically we do whatever the patient, whatever the patient wants. Usually they're coming into me with an opinion about what to do. Paul, any comments on that?
No, I think that'll be the challenge. I'll be curious to kind of parse through all of the data that went into the recommendations and cause the revision. But it's there by moving the age to a younger bracket, we're going to be seeing more women with dense breasts. And since there is uncertainty as to what to do with that, I'll be curious to sort of see how that plays out. But so I'll have to really do the deep dive in literature.
Yeah. So the American College of Radiology and the Society for Breast Imaging, they put out a joint public comment, Paul, and this is not just like we think this is good, we think this is bad. This is like 11-page document. There's like 37 references. They're talking line by line. They go through about what they agree with, what they disagree with. So they agree with the screening age of 40, but they think it should be annual screening of women starting at age 40. And they think that they think that we should continue to screen women, not just indiscriminately stop at age 74, but that we should continue as long as the woman is in reasonably good health and has a reasonable life expectancy. So I'll link to that as well. It just seems like, to me, looking at this, someone who's not an epidemiologist, this seems like you have a bunch of smart epidemiologists at USPSTF and clinicians there. And then you have a bunch of smart people, radiologists and the people in the Society for Breast Imaging who have just a differing interpretation of the literature. And the ACR and the Society for Breast Imaging were upset that no breast experts were included in the USPSTF group making the recommendation. That was one of what things they called out. But that's that's it. Rahul, as an epidemiologist, any comments on this? Is this normal for epidemiologists to fight over the same data set and have different conclusions?
I mean, I think you have both hit on important points about, the challenges in translating recommendations for a population to the care of the individual patient. And, we were talking before starting recording about, if you have a patient who's, sort of living a very healthy life and, has a expected life expectancy of many more years, you might decide to continue screening after, the age at which, the recommendations say you start to peel that back. So yeah, it takes a lot of individualized thought, and this kind of tension exists a lot between clinical medicine and public health, for sure. It's difficult.
Yeah. All right, Paul. So tell us a little bit about Kratom, which apparently it's not new, but may be new to some people in the audience who aren't, who aren't in the loop with this kind of thing?
Yeah, it's something I heard of relatively recently, and I think I saw it even advertised when I was sort of doing my tour of that. I believe it was the Southwest, where I saw sort of billboards for it and sort of advertised availability. So it's around and has been around. So kratom, for those of you who don't know, it is not a specific substance. So kratom derives from the leaves of a tree that's indigenous to Southeast Asia, where it's actually been used there for centuries. As I wrestle with my cat, apologies. Where it's been used for centuries as a medication. It's been used to treat things like hypertension and chronic pain and cough and fever. It's been used a lot. And the way it was traditionally used is you would either chew the leaves or brew it into a tea, which becomes relevant because, of course, as it's made its way west into the United States, we're now selling it in this hyper concentrated form at doses that had previously people had not been exposed to. Because if a little bit is good, then a ton is obviously much better.
Doesn't Red Bull have like a kratom flavor or something?
Well, I think it is included in sodas as well, just to kind of, because the taste is apparently fairly gnarly, is my understanding. So anything to kind of mask the flavor is probably an important thing to do. And it has like over 40 alkaloids, I want to say, and probably the most important ingredients I'm going to probably butcher the pronunciation, is metragenine, along with 7-hydroxymetragenine, which is actually a metabolite of metragenine. And it's fascinating. The receptor, it seems to work on every psychoactive receptor there is. So it is a mu agonist, but it works in such a way that it does not cause the respiratory depression and sedation that is sometimes seen with or seen with opioids. It also seems to have some adrenergic agonism. It has some alpha-2 agonism. So it's at different doses, it seems to have different effects, and includes, like, people have been using it for increased alertness. They've been using it for analgesia. I've heard about it being used as almost like a pre-workout, because if you're sort of treating pain and also trying kind of increasing your energy level, it makes sense, right?
Yeah.
So
I heard that the stimulant effects are at the low dose, right? Forgive me if you already said this. The stimulant effects are at the low dose, and the opioid effects, the pain effects, are more at the high as you go up on the doses.
I believe that's my understanding. And then also whether or not there is higher proportions of the 7-hydroxymetragenine is also important, because that's the one that is really active. I think it's like more, I forget how many times, like 10 times more active than morphine, I want to say. And we'll go back and correct the show notes if I'm wrong about that. But certainly more potent than morphine too. So there's a lot of variability. The question is like, should we be panicked about this? It's the legalities behind it are fascinating, by the way, Matt. It is not recognized by the FDA as a nutritional supplement. It was going to be made Schedule 1 by the DEA, but there is like this large kratom advocacy group, because people are using it to treat their pain, that actually halted that, and the DEA backed off, which I've never heard of anything like that. So it is now listed as a substance of concern, but is not federally legal. It is not legal in certain states, but it is at the federal level. It sounds like as a result of advocacy by people who are really helped by it. It's just kind of being watched for right now. And it's important to note, I think, it's substance of concern. It is because of its mechanism. It seems to be safer than full opioids. The adverse effects are largely from case reports. It's not super well studied. It is not, even overdoses associated with it are almost always in the setting of polysubstance use. So it's the question is how worried should we be about that? And right now we just don't know yet. So I think that so there's this Dr. Kirsten Smith, who's sort of a recognized national expert on this. She's a PhD. Who has made kratom kind of her whole expertise, and she's quietly one of the most interesting people alive, has made really sort of thoughtful and articulate pleas for just good research and good case reports on patients who are using it. So the whole big takeaway for our listeners is know that it exists, it's out there, it's becoming more prevalent, and maybe ask your patients who have existing opioid use or substance use about their use, just so that you're aware of it. But like, it's not something to panic about yet, but just kind of keep your eyes open and sort of pay attention to it. There are, I should mention, case reports of people with kratom use disorder and people who've developed dependency and withdrawal syndromes to the extent that they are actually even treated with buprenorphine. So it is, there are people who are treating kratom use disorder. So it's I'm not suggesting it's entirely benign. I'm just saying it is not super well studied, and there's not a whole lot that's known well enough about to make sort of broad sweeping generalizations. But just kind of keep your eyes peeled, because it's becoming more prevalent here in the West.
My recent trip south in gas stations in, I want to say, Virginia, North Carolina, South Carolina, they just had it right there at the counter. So it's around. gas stations.
Yeah. It's gas stations,
Wow.
head shops. Yeah. The other, I should mention real quick, and I'm sorry for running so long about this. The other really fascinating use for this is for harm reduction. So patients with opioid use disorder who are experiencing withdrawal have been using it to mitigate those withdrawal symptoms, and successfully, I might add too. So there may even be a therapeutic role for it. But again, it's sort of still very new kid on the block, and not a whole lot's known about it. But it's just it's something to watch, I think.
Paul, did you want to promote a podcast by Dr. Kirsten Smith?
Oh yeah, she was on the Addiction Psychology podcast. There was an episode with Dr. Smith about kratom use specifically that I thought was really eminently listenable and really, really helpful.
Yeah.
And she's written about 20,000 million papers on it. So we'll link to a couple of good reviews in the show notes.
Excellent. All right. Well, I think we've done a great show. Any last comments before we get to an outro?
I'll just say I was poking back through the methods section of the hot flash treatment paper, and I stand by what I said. It's really confusing. I don't I don't think I fully understand. I also asked ChatGPT to explain it to me like I was a 12-year-old, and it didn't really make it that much clearer. So I feel better about that.
Oh, that's a good idea. I should start doing that for statistical stuff to see if it helps. Maybe it will.
Which makes me feel world better, by the way, Rahul. Like if this is where you're at, I feel like a hero. So that's great. Thank you for sharing that. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
There you go. It's your time to shine, Rahul. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, each month, you'll get our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show. You can send us an email to askcurbsiders@gmail.com. And of course, you can find the show on YouTube, Spotify, or Apple Podcasts, really anywhere you get your podcasts. Reminder that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. Wanted to give a special thanks to Paul and Rahul for helping to write and produce this episode, and to our whole Curbsiders team. Our show has technical production done by the team at Podpaste. Elizabeth Proto runs our social media. Kristen Chumanchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Rahul Ganatra.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.